In this next series of slides, we're going to talk about how to fit Comfort 15. We fit the Comfort 15 from a 13 lens fitting set. The sag or depth of these lenses varies from 3,500 microns to 5,000 microns in 125 micron steps. The aim of the lens is to find a depth which exceeds the apex of the cornea by approximately 1 to 150 microns. No topography, OCT, pentacam is needed. The lens can be purely assessed using a slit lamp and fluorescein. So how do we choose the first trial lens? Essentially it's based on eye condition. There's a guide within the fitting set that gives you an indication of which numbered lens to use based on the condition and the severity of the condition. So the more severe, the more protrusive the condition, the deeper the sag or the deeper the depth of the lens is required. Often for early or emerging keratoconics, somewhat normalised, we're looking at around 4 to 5 as a starting lens, so around about 4,000 microns. To insert the lens, it must always be filled to the brim with saline, and fluorescein needs to be added at the point of filling the lens. No fluorescein will get behind the lens once it's in situ. Now the patient needs to be looking down at the floor, whether they're standing or sitting. Their nose must be pointed to the floor, the chin tucked in as close to the chest as possible. Now the lens can be inserted either using a DMV inserter or as a tripod on 3 fingers, as the following picture will show. With the patient looking down, get them to hold their bottom eyelid out of the way. You, the practitioner, hold the top eyelid out of the way. With the lens on the fingers or on the suction holder, slowly bring it towards the patient's eye. Bear in mind they'll react to the sensation of the saline first. At that point you know that there's only another 4 or 5 millimeters to go to place the lens gently onto the conjunctiva. After the fitting process is finished, we need to remove the lens. The simplest way is with a small RGP lens sucker. Now it's really important that we place this either at the top or the bottom of the lens, but never in the centre. If we put the sucker in the centre of the lens and pull, the lens will not come out. What we're aiming to do is have the sucker at approximately 12 o'clock, hold the patient's upper eyelid out of the way, and pull the lens down and out in an arcuate movement. This will release the lens from the conjunctiva and it will come away relatively easily. Alternatively, we can teach our patients to use the lids in a similar kind of way to how we would do with the standard RGP. So we're getting the lids underneath the edge of the lens and flicking the lens out.